I'm Dr. Alana Yurkowitz, and this is Hard Medicine. What is dependence, and is medicine equipped to handle it? That's the subject of my conversation with today's guest, Leah Labresco-Sargent, a writer and thinker. In her new book, The Dignity of Dependence, she challenges the idea that needing others is an aberration, arguing instead that it's the default for most of us. Can we build a society that recognizes this? Does medicine? And if not, why not? If the very institution designed to care for people has blind spots when it comes to disability and need, what does that say about the rest of society? We talk about the realities even healthcare struggles to hold: chronic illness, pregnancy, end of life, and the toll of treating these as exceptions: financial strain, employment limitations, compassion fatigue. These are not edge cases. They're ordinary life. Can the culture of medicine be the first to shift, to become a place that truly centers human need? Can medicine make peace with dependence? Leah Labresco-Sargent, welcome to Hard Medicine.
Thank you for having me on.
I loved your book, and I want to start with definitions. Your thesis, if I could summarize it, is that we are born dependent and we die dependent. In the middle stage of life, we treat autonomy as the default, but dependence continues to shape us at various points along the way. You argue that this dependence is not an aberration, but an expected part of the human experience, and that we ignore it at our own peril. How do you define dependence, and where do illness and disability fit into that definition?
Yeah, I think part of how I think about dependence is that, we cannot sustain ourselves. And that's really trivially true when you think about the things like I don't grow my own food, I don't, design my own semiconductors. But in a very real way, we do not find that our bodies are strong enough and stable enough to carry us through our life without help from others, whether that interruption comes through pregnancy, the flu, injury, disability, end of life memory issues. We shouldn't think of ourselves as sufficient for the lives we want to take on.
And you write in the book that need is not an edge case, I quote. And I'd say the same is true for illness. I was thinking a lot about illness as I was reading. 60% of adults have at least one chronic illness, many are invisible. And I want to turn to medicine because some of the very institutions designed to care for people neglect this reality. And I could think of a few examples: lack of handrails in exam rooms to
Hmm.
help patients get up and down on the tables, which I do every day; shared rooms in the hospital where patients with dementia can be put together, not have access to a window, and get worse before they get better. It's almost a known secret that the hospital is one of the worst places to be for healing. If institutions built around care can overlook dependence, how optimistic are you about the rest of society?
I think part of this problem comes out of viewing the particular needs of someone who is sick as though you can take individual needs in isolation and address them without regard to the person. So you say, okay, well, this person has low potassium and we're putting more potassium in them, so everything's going to be all right. Even as, you have someone who's also trying to sleep and you send a nurse in every 4 hours to wake them up and take their blood pressure. And I think, focusing on some of the metrics you can measure as though the human being is just a system of inputs and outputs, again, misserves the person at the heart of it. And I understand why things wind up this way, especially in a hospital where you're there because there's a real emergency. And as much as people may want to focus on the person in front of them, they also have to adjust your potassium levels or you'll die. But I think some of that sense of, all right, we're here to fix a discrete, isolatable problem. And once we're done with that, we're done, carries over to the whole attitude of how we treat each other, as though we're kind of stable at baseline and need to fix a few odd quirks that will then return us to that perfectly healthy baseline. And I think the alternative is kind of living in relationship with your body as something that has a lot of foibles and weak moments and saying, well, how do I design a life that can accommodate that variability?
And I think a good example of this, that this can be done, is looking to pediatrics. It's a wildly different experience for me in the pediatric hospital versus the adult hospital, where it is recognized that little humans have these foibles And all of that needs to be taken care of in order to get the person better, that it's not just a system of inputs and outputs.
Well, and actually, one of the kindest things that was done for me was stolen from the peds department. I know. I hate seeing IVs in my arms. I don't like them, period. They're gross, but I really don't want to see the needle and it's just sitting there the whole time. And for all my deliveries, I've been group B strep positive, so I've got to have the antibiotics going the whole time, which I hate. And I've asked every time I go to the hospital, can I cover the IV port in case I don't have to see it while I'm laboring? And most of the time, what they do is they take a hospital sock and they cut off the toes and then just slide it over my arm, which, to be honest, makes a huge difference. So I'm grateful. But other times they go, oh, let me ask a peds nurse. And then they come back and they're like, would you like bees or trucks? And they've got a little wrap to put over it for me.
You actually have choices to make the hospital experience a more pleasant stay. And look, I mean, I understand. I sometimes have to tell people the hospital is not a hotel. You're not going to be getting the kind of care that you get if you pay for a hotel or a resort. But at the same time, there are so many low-hanging fruit just like that
Hmm.
we can do to make people's experiences, and I would say just not more pleasant, but more critical for recovery, right? Like, as you mentioned, if you're waking up every 4 hours and you're 80 years old, sleep is a huge part of your ability to,
Yep.
and not sleeping can delay your recovery.
That's right. And again, I think that's kind of dividing in an unrealistic way the parts of your problems that are medical problems that, show up on a lab readout that are related to illness versus being a human being problem where you do need sleep. And even though we're not prescribing it, it's important for you. You see the same thing again, especially around birth when it comes to things like doula care, where if doulas were drugs, they would definitely be covered as preventive medicine, maybe with no copay for the patient. When our studies of what it means to have someone just accompany you all the way through labor, answer questions, provide support, it makes a big difference in things like C-section rates and people's sense of whether their birth was traumatic. So if you could put it in the IV, it would be covered. But because it looks soft in this way, there's no clear mechanism of action. A doctor isn't prescribing. It's just there's a kind person who's seen births before. Well, is that really medicine?
And I think that's a perfect transition to caregivers, because when you were writing about doulas, I also thought about caregivers. Like, if we could put a caregiver in the IV for an elderly
Hmm.
said, that would be worth more than many of the medications that we prescribe. And one of my favorite chapters in the book was called The Limits of Labor Language. And I want to give an example here. You use the example that if two stay-at-home mothers swapped children and paid each other $30,000 a year for caregiving, the economy would appear to grow by $60,000. But if each cared for her own child, that same labor would be treated economically as worthless. So I'm wondering your thoughts. Why is economic language an incomplete framework to discuss the value of caregiving in particular?
Economic language and kind of that GDP lens is always framed around the kind of work we would not do but for the fact we're paid. And it's usually framed as though that work is something that's pretty interchangeable. I could watch your kid, someone else could watch your kid. There's just a prevailing market wage for this work, and it doesn't matter that much who does it as long as they're in this band of qualified. But that's really not how we approach care. That if you've had someone be your kid's nanny for a year and a half and you've got 6 months to go and now you're switching to someone who's equally well qualified, there's no way you value them the same amount because your existing nanny has been with your kid all this time, has these memories of their development. So this is not something where you can talk about labor as kind of interchangeable parts. And similarly, we kind of just can't speak sanely when we talk as though care is only valuable when it's compensated in this way, because then we can measure what it's worth, and that parents caring for their own kids are kind of indulging themselves in a hobby that doesn't benefit anyone outside their own family.
One of the things you hit on with caregiving is the value of continuity, and the value of continuity that cannot be captured in any sort of economic framework, whether it is the family member who is the caregiver, or in your example, the nanny, or let's say the caregiver who's taking for the elderly patient with dementia, but knows that person and has been taking care of them for years. There is no, to my knowledge, economic way to incentivize continuity of caregivers.
Hmm. Yeah, well, I mean, ideally, you'd have parents or have their insurer, whoever is footing the bill, have a way of kind of offering longevity bonuses, but that's really not how we structure this by default. And often care is so expensive that parents are kind of already paying the maximum they can afford, whether that's for childcare or elderly care. So it's not easy to say, and we're bumping this up by 5,000 a year over and above a cost of living increase, to kind of recognize what this continuity means to us.
And I want to talk about the economics in the workplace as well. You write a lot about that. Many workplaces can be openly hostile to illness or disability. As a physician, I have learned that my signature can be one of the most powerful tools I have to give chronically ill patients protected time to step away from work that otherwise treats them like widgets. They can step away to inject insulin. They can attend appointments. They can take their medications. I often write for intermittent FMLA for people to be able to do this. Yet often I and my patients face employer pushback anyway because modern workplaces are built largely to squeeze maximum productivity from able-bodied workers. I believe that squeeze leaves zero room for dependence or illness. How do we create workplaces that treat workers like real human beings with real needs and not widgets?
I'm not sure exactly how we get there, but I can talk about an example of somewhere that does this differently and how they got there. There's a group called the Bruderhof who are a Anabaptist community, and when they built a factory as part of the way they were supporting their community in the market, and they hold all their goods in common. So the point of the factory isn't to enrich the owner of the factory, it's to for the community together to make something that is viewed as valuable by the world that the world will pay them for. And in the same way that monasteries might make beeswax candles or have some other industry that helps support their work. So when the Bruderhof were designing their factory, they said, well, this is a factory that's meant to employ our community. So we're not going to start from the assumption of we get to pick whoever we want to work here. We can't say we're only hiring 20 to 30 somethings who don't have kids. And we assume, though of course we won't say they have to because that will be illegal, that our structure of work will force them to quit when they have kids. They're saying, all right, well, we're employing almost anyone in our community, including the elderly. So they designed their factory with the assumption of this factory needs workstations that accommodate people who can't stand up for long periods, who have mobility issues in their hands. So what can this workflow process look like so that there is a space for a really wide range of workers? Now, that's not the assumption that most workplaces take. They say we're trying to draw from either this whole municipal area, this whole state, increasingly with remote work, this whole world, for whoever will fit best into this very narrow niche we've created. If anything in their life happens that perturbs them and pushes them out of that niche, well, we'll go find another person. And the Bruderhof had this sense of stewardship of their community. They had to design the job so it could employ the people nearby. And I think that's just not a way that most workplaces think through this.
Think that's a great example. And no, no workplaces or very few workplaces here think like that. They are financially incentivized to do the opposite, to treat people like interchangeable parts. And if they can't squeeze maximum productivity out of them, they're not really thinking about the big picture of the employee as a worker that has needs. And as you write about in the book, it's like those needs are expected, right? This is not an aberration. It's not an edge case. Something is going to happen, whether it's the flu, whether you get pregnant, whether you get sick with anything, any chronic illness that requires stepping away to attend an appointment or take your medications. This is going to happen to nearly everybody, and it's treated like people are imposing upon the employer when this occurs.
That's right. And, I think there are industries where it's clear this is insane. You see restaurant workers who don't have sick leave. And if there's anyone I don't want to come to work while sick, it's not me who's a think tanker who's remote 3 days a week, where I do have sick leave. But if I'm kind of draped over my computer with a fever, that's not a problem for anyone but me, per se. But when you have whole industries about serving and preparing food where folks don't have sick leave, it's profoundly self-sabotaging to the whole purpose of your restaurant to have people come in sick. And I think increasingly the thing that we often talk about this through the lens of sick leave as this kind of sudden catastrophe for the worker that they don't have space for. But increasingly, I think the thing we're going to see employers either accommodating or not accommodating is going to be elder care. As the boomers are getting older, more
Yes.
and more of their kids are on the hook for figuring out, well, what am I going to do and what compromises can I make And what level of care does my mom need? And because they had fewer kids, their needs are going to be spread out over fewer people. So, what they themselves, the boomers, did for their parents is going to be a much bigger lift for their own kids because the kids will not have as many brothers and sisters to share the work with, and their parents will live longer with big medical needs than their own parents did.
And it shows the long-term nature of caregiving that I also think workplaces are mostly unequipped to deal with, right? Like most are equipped to deal with the flu because you're out for 2 days or 3 days or you're out
A
with a
week.
week. Right. But pregnancy, which we'll get to
Hmm.
later in the conversation, I think is a good example of long-term needs that need to be accommodated in the workplace. But if you are taking care of an elder patient, that can stretch on for many years.
And this is something I was on a kind of task force for coming up with some best practices or asks around paid family leave. And even pregnancy, it's a lot easier for people to kind of coalesce around something that seems fair. 3 months is one of the standards that people appeal to, even though we're not even at any level of mandated pregnancy leave that's paid in the US. But there's a sense of, well, you need time to physically recover from birth, to establish breastfeeding if you're trying to do that, and kind of get through the not sleeping at all period. And 3 or 4 months will get you there, sort of. And that's enough that it's imaginable workplaces can handle it. But when we talked about elder care, we were saying, well, what would that be? Like, well, it can just go on for years and years and years. And for a number of folks, the needs of your parent will mean you can't hold a normal job under normal circumstances for just an indefinite period. So, what would a paid family leave program look like there? And we kind of came up with a very unsatisfying answer of maybe a 2 week leave period for people who are entering hospice, which again can be open-ended, of just you should have this much time off work paid to solely focus on how you're going to plan for this open-ended commitment. The 2 weeks are not going to get you and your mom or your dad through all of this, but it means you will focus on nothing else but this new problem for a bit. And then you'll have to decide, am I going back to work at all? Am I going to part-time? Do I need a leave of absence? But it was very hard to design a policy that could accommodate the range of needs people would have.
What about intermittent FMLA? Can that cover it, right? Like you give someone, let's say, 1 or 2 days off a week for anything unplanned, but as you write in the book, really kind of expected.
Well, I think it's important to remember that that can help for the right worker in the right job, but FMLA is unpaid. So for many workers, it's something they're entitled to in theory, but can't afford to use.
Yeah, they're entitled to it in the sense that they can't be fired for taking it, but they're not actually paid for that time off.
Exactly.
So I do want to spend some time on pregnancy, which I think it helps to set the table for our listeners who have not been pregnant, for what that is. For many women, and I will include myself in this category, it is the sickest they have ever been, if they have the privilege of being healthy before pregnancy. For me, it was like being on chemotherapy. I was
Mm.
nauseated, 24/7, vomiting every day, sleeping 12 hours a day. The nausea and fatigue just stretched out for months on end, and I still worked and for the most part just kept it under wraps. And while I appreciated the very generous maternity leave that was given to me after I delivered, as you mentioned, there was no mandated pregnancy leave, which was kind of stunning to me that I didn't have any accommodations while the sickest I've ever been, right? It was almost a disconnect. Like if I got the flu, I would be treated with way more accommodations than during pregnancy. How do you think about that in the workplace?
Well, I had to ask for leave while I was in my third trimester because I had a threatened early labor with my third baby. And the medication I was put on to make sure he didn't come out just made me so exhausted and miserable that I realized I just only wanted to lie down and felt wretched. And so I went to my office, which did have a certain amount of leave that was available. And I took 2 weeks off, in maybe week 32, 34, or something until I was at the point where I could taper that medication down because it wouldn't be as much of a problem if he suddenly started to come. And that was great. And that was kind of a mix of my office having a policy versus just real flexibility when I said, I can't work like this. What are my medical leave options? And that's not something most people have on the table at all. But more than that, I think even if it were available, women would feel a lot of pressure not to opt for that kind of leave. And it's because it feels dangerous to say pregnancy can really upend your life for months, not just when the baby is born, but in that whole run up, and that some women will have HG and have kind of completely debilitating nausea that may require hospitalization to treat. And some women, while kind of not having anything that counts as a pathology, will be so exhausted they can't get through a full workday. But if you cop to that, you are conceding that men and women are meaningfully different in this way, and that it is, from an employer's perspective, if they're just counting inputs and outputs, it's worse for them to hire a woman to do this job because the woman is more vulnerable to this kind of illness, debility, interruption. And I think people are pretty invested, and with good reason, based on the lack of trust of when women have this notable asymmetry in our lives, especially around fertility, about trying to cover it up rather than seek accommodations. Because the fear is not only will the accommodations not be granted, but once you let the men know pregnancy can be this hard on us, they will want to pervasively not hire women in high pressure, high commitment jobs.
And there's data to show this happens. I'm listening to
Hmm.
another book now, which I also recommend. It's called Having It All by Corinne Lowe.
Hmm.
And she writes about how FMLA for pregnancy gave employers a justification to discriminate not just against women who were pregnant, but anyone who could become pregnant, which was really young women who were paid less and promoted less. And the fear, I think, as you alluded to, is many women would opt out, would not opt into this because of fear of these unintended consequences for them and for their colleagues.
And I don't have any single great solution to that. A lot of what I'm doing in my book is pointing at some of these asymmetries where women have different needs than men that aren't accommodated. And my pitch is, let's take the risk and take the hit and ask for what is genuinely just and, push hard to make sure there isn't backlash. Because what we have now is a system in which there's not as much explicit backlash, but you're still compromising on what you know you need. Now, that's not a very satisfying solution because I'm not giving anyone the promise. And when we rise up and demand to be accommodated fairly as women, that we're going to get what we're asking for. But I just don't see a way to get there from here that doesn't involve taking that risk.
I completely agree with that. I think you start the book by saying the world is the wrong shape for women, if I'm getting that right.
Hmm.
And I love that framing because I think about so many other situations in medicine, and it's like we don't pretend that elderly people are just fundamentally the same as younger people. We don't pretend that people who need handrails are the same or that gla people who need glasses are the same. Um, and by just ignoring that fundamental starting place, that people have different bodies and different, I would call them medical needs because pregnancy is a state of a very different medical state than when you're not pregnant. It's just not a starting place to get anywhere to treat people like people.
That's right.
I want to also just go back to the workplace and how the medical workplace treats its workers, because again, just like adult hospitals that perhaps don't take care of their patients as well as they do in pediatrics, if anyone should understand dependence, it's people in medicine taking care of their employees. And I would say this is not so much economic, but just the culture of medicine assumes that clinicians are the pinnacle of health. And it's
Hmm.
almost like there's this bright line, there's us and there's them. And I can give you two examples of that. One is that we regularly work 28-hour shifts, which are hard for anyone. But I was working with a pregnant colleague who was doing 28-hour shifts, or just imagine all the invisible illness that someone could have where your body is being pushed to the brink like that. And then another example I could think of is, when COVID hit, we all diligently put on our masks when we went to see patients, and then we went back to the shared workroom, and everybody, just kind of gleefully took off their masks because it was impossible, right, that we could get each other sick or that anyone in that room could be immunocompromised. So I want to hear your thoughts because you have a lot of experience, I think, from the patient perspective, taking care of yourself, taking care of people you love. about medical culture and why medical culture kind of sees dependence this way, where there is this imaginary bright line between people who work in medicine and people who utilize medicine.
I think some of this comes back to our conception of what a doctor is, that a doctor is this expert who knows your body better than yourself and who's going to be able to, like someone fixing your car battery, reach in, do something purely on their own efforts, and then restore you back to being a normal person. And that when that doesn't work out, it's frustrating for the patient and the doctor. And it kind of pushes on this question of, well, is this even medicine? Is this doctor a good doctor if they can't fix my health issues? And I think, one of the ways that really goes wrong in a big way is that this is just not actually always in a doctor's power to deliver. And when we set up this expectation, this idea that there are healthy people, and sick people should have something kind of definable wrong with them, the doctor finds, fixes, and then restores, we're setting in patients and doctors up for disappointment versus saying, a patient is a dynamic system, also a person, right? That may or may not have what we think of as full health in reach, or fixing one thing may involve compromising some other part of their quality of life in a way that's unendurable to them. So you're really trying to say, all right, what are the possible futures for this patient? How can we get there? And how can we collaborate to better their life rather than perfect or restore their life? There's a quote I love by Dame Rebecca West in her book Black Lamb, Gray Falcon. And I'm going to warn your listeners, this is a book about an Englishwoman traveling in Yugoslavia, nonfiction, between the world wars. She's very opinionated. She's very prone to broad statements about various ethnicities with great gusto. But there's a quote she has about a tuberculosis hospital she visits that really has always stuck with me. She says, "Here is the authentic voice of the Slav. These people hold that the way to make life better is to add good things to it. Whereas in the West, we hold that the way to make life better is to take bad things away from it.
Hmm.
With us, a satisfactory hospital patient is one who, for the time being at least, has been castrated of all adult attributes. Uh,
Mm.
you know, with us, a suitable hospital diet is food from which everything toxic and irritant has been removed, the euchanised pulp of steamed flesh and stewed prunes. But here, among the Slavs, a patient could be adult, primitive, dusky, defensive. If he chose to foster a poetic fantasy or personal passion to tide him over the crisis, so much the better. It was the tuberculosis germ the doctor wanted to alter, not the patient."
This book sounds great.
It's great. It's a massive book. It's very insane throughout. I love it. But that really stuck with me because it feels like a lot of the time the assumption is if you're sick, there's something that's gone wrong and we'll find it, fix it, remove it, and then you will be restored to what a human being naturally is, healthy. And that's just untrue. I like better, and I think there is a real tradition in the West of this, not only for the Slavs, Hildegard von Bingen talking about what it means for a doctor to assist a patient by connecting to, which she doesn't use the word homeostasis, but we would call homeostasis is like tendency of the body to observe itself and interact with itself and correct itself or try to. So that the doctor is someone who collaborates with the body rather than someone who simply operates upon the body.
Yeah, and I think on one hand, I am very hesitant to share details about my personal life when I'm treating patients. I don't want the focus to be on me. I don't want to share, hey, I'm vomiting all the time, right? When I was pregnant or I had gestational diabetes, I gotta go. I gotta go inject some insulin. I'll be right back.
Hmm.
But
Hmm.
at the same time, I think there is some value in showing your humanity as the person who's supposed to be taking care of people. What do you think?
I think, both it's valuable, but I also kind of want to caution folks from saying that you have to bring all the hardest parts of your life to work.
Yes.
Because I really don't want to do that in any of my jobs, and I don't want that to be the bar for becoming a doctor. And I think one of the other ways of doing that, and you can correct me if any of this is, HIPAA violation, is just talking about as you practice, that your patients have a range of experiences and preferences and trade-offs. So saying, all right, well, you're facing gestational diabetes, you're figuring out what to do. My patients have opted for a range of approaches. I most often steer people towards X, which I think is pretty good and what I would choose for myself, if that's true. But I have patients who opt for Y because they're really concerned about this trade-off, and they feel like even though I don't like this side effect of Y, they feel like it's balanced by second side effect of X. How are you thinking about these dynamics? So there's this idea that both there's choice and variation, and that in many cases, the right step forward is not a totally uniform one, and a patient kind of picture themselves among this group of similar patients who might, with all the same information, make different choices. There's a bit in Emily Oster's Expecting Better that I love, where she's running through the case for and against epidurals, and she has this big pro-con list, and she's looked at all the science, and she sits down with a friend, and they look at the exact same data, and Oster says, all right, well, I really want to avoid an epidural based on this if I can. And her friend goes, this makes me feel good about opting for an epidural because they weigh the trade-offs differently.
I remember that part of the book. That part really spoke to me too. It was very memorable. And I think that is the ideal way to practice medicine. And my listeners who are my patients can correct me if I'm wrong, but that is how I try to practice medicine. And something that I often tell patients is when there's a choice, I lay out what the options are, and can make a different choice depending on what's important to them. But I will also tell you when I feel really strongly one way or another, because
Hmm.
people do want my opinion, right? People come to a doctor for a second opinion, not a second set of facts. And sometimes I do feel very strongly. Actually, often I do feel very strongly. And when they ask me straight up, what would you do if this were you, or what would you do if this were someone you love? I tell them, or even in the absence of that question, sometimes there's just one path that I think is the right path. And so I try to be very clear about situations where you have a bucket of options to choose from, and there really are many rational choices here. That is a personal decision to you, and decisions where it's not really a decision.
Yeah. Well, I think the other kind of helpful frame for that, at least for me on the other side of the table, sometimes I ask, well, for people who opt for X and feel later unhappy they did it, what are the reasons they tend to bring up? And I can kind of hear that out and go, okay, well, some of those resonate with me, some of them don't. And sometimes that's the only way I can get a doctor to talk as though there are options on the table when they're like, X is better than Y, you should do X. I'm like, sure. Like, what do the first few days after X look like? To kind of hear them paint a picture rather than just say, well, I've made my decision. I was really grateful for a surgeon I had when I unfortunately lost a baby through an ectopic pregnancy. And I had the choice about whether I was going to have a salpingostomy or have methotrexate. And the surgeon was really great and talked things through. He was like, yeah, I would recommend methotrexate. You're a good candidate for either, but I think it's much better. And, obviously he can't quite say it's what I would do, but he said, it is what he would opt for were he a woman and capable of being in this
Hmm.
position. And
Hmm.
my big question was, because he's going through the different risks, it's like, you can take this, but you might need a second dose, you might have to return. I'm like, how many of your patients tend to come back to the ER after taking the methotrexate? And he's like, probably about 50%. And for him, that was because not that they all had a crisis, but because the side effects were similar enough to, a serious ectopic pregnancy emergency. They had to come get checked out, and a bunch of them were fine. And I'm like, okay. So if I state this back to you, if I do the methotrexate, you know, I may avoid surgery. I go home, like the next couple days involve a lot of watchful waiting, but I may be back here having the surgery anyway, and I might need to drop everything to come back to the ER for something that isn't an emergency. And he's like, yes. I'm like, and if I have the surgery, I'm locking in all the downsides of a surgical outcome, but you don't think you're going to see me again. He's like, yes. I'm like, I want the surgery.
Hmm.
And he's like, well, I would not do that, but you did a really good job summarizing what will happen next.
That's just like the Emily Oster. I mean, I would listen to that set of data and say, thank you. I will take the methotrexate.
Yeah, no, and I was so glad I didn't, including because later, and I kind of can't believe this happened to me. I was in my coffee shop well afterwards, and my local coffee shop, and a woman just collapsed at a table, and I was nearby as they were making the 911 call, and her husband kind of wasn't great at making the 911 call, which is understandable in that moment. And I hear him saying like, yo, I don't know, she took a cancer drug, something, something. And like, I did come over. I'm like, sorry, are you talking about methotrexate? Like, does your wife have an ectopic pregnancy? Like, yeah. And I'm like, you should tell them that really explicitly right now, right? Like, and she was okay. I had a like nice coffee with her after the fact,
Mm.
but she did not feel like when she left the hospital, people had given her any level of informed consent readout that
Mm.
she might have a big episode that led to her calling 911. And if she had known that, she might not have been out at a coffee shop. And if she hadn't been with her husband, there wouldn't have been anyone nearby when she lost consciousness to tell folks what was happening right away. Versus, when I had ectopic pregnancies, I used to carry around an index card that said, please call 911 that I've written out and like wrote vital details. So I was like, if I lose consciousness, I'm just going to like pull out the card and hold it up
Right,
as I go
right.
down. But she just hadn't gotten the warning first. My doctor gave me all the information I needed to make and support either choice.
Like my patients who are on immunotherapy, I have them carry around the same index card that this is not chemotherapy. These are the really serious effects that can happen from this
Yeah.
particular type of cancer treatment. Go straight to ED, do not pass go type of thing.
hmm Yeah, and
But
that makes a huge difference. And I understand why some doctors don't walk people through that to the same extent they should, because it sounds like you're going to scare people off when you're like, you should carry a card that's going to warn people for the next few days. But it's really important to know.
yeah, I mean, I often tell people most of medicine happens outside the exam room. I mean, so the
hmm
most important thing I can do is just counsel you on what to take seriously, what's a red flag, what is just part of being human, and so that you can triage yourself and know when to come in and get care.
Yes. And it's so rare that I hear that. I often the last question I ask in an appointment after I've given the doctor a fair chance to bring it up themselves is, what symptoms, if I observe them would mean I should get back in touch? And it's just not brought up proactively. It's like, and if anything happens, just give us a call. I'm like, what
Oh, what
specifically
is
are you
anything?
talking about?
Yeah. What if I have an itch one day? Should I call the
hmm
In my particular field now of I specialize in cancer survivorship. So these are people who either are getting active treatment for cancer or have survived a cancer many years ago. What I often tell people is my 2 week rule because it is very normal to wake up one day and you have an itch, or you wake up one day and your lower back hurts, and then 3 days
hmm
later it's better. And so my 2 week rule is just if you have any new symptom, new and persistent for 2 weeks, you come in.
hmm That's great.
Hopefully that helps people when you can't be as granular about you're going to syncopize, right? Or you're going to have
Yeah.
pain here. It's hard to know some of those details. So, on that note, I do want to talk about a different expected chapter of life that we often pretend is unexpected, kind of like pregnancy, which is the end of life. Many people, my patients included, and I think the data support this very well, fear being a burden to the people they care about at the end of life, whereas the loving family finds it the opposite. They find it a privilege, although it's one they've never wished to repeat, to take care of someone they love through the final chapters of their life. From your perspective, what is meaningful or even fulfilling about caring for a dependent in that way through the final chapter of life?
I think a big one I want to say up front for me as a Christian is that our goal is to die in friendship with Christ. And that means really seeing death as part of the work of living, as a chance to grow deeper in love, both with God and with the people around you. And it would be a big thing to miss. For Christians, the ideal of I hope I go peacefully in my sleep unaware isn't really an ideal at all. That dying is something to take on as a project, rather than something you hope you miss entirely. Now, obviously, it's not compelling to everyone, but I do want to say up front that that's my perspective on it. But I think beyond that, part of the witness you offer by caring for someone is, I love you simply for being. And at this moment, as my parent, where you can no longer care for me, where your life genuinely is an interruption of some of the other plans I've made for myself, where there's no sense you're going to get better from this and then it will be your turn to take care of me, all of that is over. What remains is this unconditional love that isn't a meritocratic love at all. It's not a love you can earn back. It's not a love you can pay back. And I think that's really a profound witness to what it means to be loved versus kind of fragile feeling love of I am loved as long as I'm doing my fair share. That all of us will have a point where that's an impossibility. And the question is whether we believe we're capable of being loved or not.
It's kind of like a love that is absent of any transaction with no.
Exactly. And I think without that, it feels like we are able to serve each other or care for each other as long as it's reciprocal enough. But once you slip out of being able to offer that reciprocality, you slip out of being someone who can love and be loved.
And I did want to take it one step further because when I was reading your book, there was a situation that I thought of where, well, I'm not sure if I agree with you, but you can tell me if we disagree, which is that caring for a dependent, of course, is not all the same. Caring for a child, you have that beautiful possibility of a future together. Caregiving,
hmm
of life is time limited by definition. But what about there are devastating situations in medicine where quality of life is irreversibly gone, and caregiving does become around the clock work to keep a body going. It's doing things like tracheostomy care, tube feeds, wound care, wiping eye drops, and it is a full-time job. And in those cases, I have seen that the toll can consume two lives instead of one. It's like instead of one life was lost, the caregiver, or, the spouse or the adult child who chooses to take on the mantle of caregiving, their life is lost too. And I personally judge no one who chooses to step away from that type of caregiving to save themselves. And as a doctor, I sometimes must explicitly give families permission to make that choice and say, I'm going to put this person in a care facility and I'm not going to be the one taking on the mantle of this 24/7 care. So I'm curious, how do you think about balancing the well-being of the healthy person with the needs of the dependent person when there is no chance of recovery and this can stretch on indefinitely?
Well, I would say even when there is a chance of recovery and you're hoping for that, you may need a lot more help than just yourself, or you may need someone to go to assisted living to recover from a serious car accident rather than do everything at home. So I don't even think this question has to be restricted to end of life. But I do think part of the way I think about this is that Eva Feder-Kidde, who's a big scholar and philosopher of care, says that often when people are overstretched and burnt out, the thing they're wishing for is not, I wish I didn't have a relationship with this person, or I wish I didn't feel some sense of obligation, loyalty, love for them. They go, I wish I had more freedom to give a yes here. And I think one of the ways to think about this is you probably can't always give a total, indefinite, open-ended yes of your whole life to someone who has big needs in that way. So you want to think about which are the yeses that are most important for me to give and for both this person and for me, for it to be me who does it, versus which are the ones where I can get help from a paid caregiver or a facility. And I don't think there's anything wrong for families, turning to a nursing home or a memory care facility. There may be needs that really exceed what you can do, just like parents who have a baby are never at fault for having them in the NICU when their needs go beyond what you, their mother, can do, even though it's very painful that you do have to have someone else do these things for your baby. So that's my overall framework for that.
Yeah, and I agree with that. I mean, I think when needs exceed your ability to personally deliver them, that makes sense. But I'm also thinking about cases where people choose to put someone, let's say, in a facility or hire a caregiver just because that's not the life they quote unquote signed up for.
I think, it depends a little on the relationship. Like certainly within marriage, to some real extent, this is the life you signed up for. But I think I wouldn't put anything like respite care in the category of opting out of care for your spouse. That to care for someone for the long term, the open-ended long term, you do have to think, well, what can I sustain? I can push myself very hard and do this for a month. But if this might be 6 months, what is the actual routine I think I can sustain and what will it take to get there?
And I think it can be really surprising to people as much as we try to counsel on what that looks like, just how all-encompassing caregiving for a very sick, chronically ill person can
Mhm.
be. And it really is a full-time job. It steals their ability to work, it steals their
Yep.
ability to do anything else that they love. And it's sad. I mean, it's undeniably sad and depressing. And I've seen through cancer, many couples it brings them together, but many couples it pushes them apart.
But I think again, the part that's missing that would make it easier for folks, regardless of where on the range of that spectrum is right for them, is, when this person is so needy, has to be helped with every bodily function, that does draw their spouse, their child in because that need has to be met. But what's missing is that next ring of my life is now revolving around caregiving, whether that's full time for me or half time, or I'm there, every afternoon at the nursing home, even though I can't do everything for this person. But, I myself as a caregiver, am kind of slipping well below what an autonomous person looks like. And there needs to be that second ring of care. And I think that's where that really is something people miss out on because you can get this briefly. It's like your husband is in the hospital with a heart attack. So we're bringing over a casserole right now during the crisis. But okay, now your husband is in hospice indefinitely at your house. Okay, well, is the meal train going forever? What are we going to do at this And Ross Douthat has written really movingly about this in his memoir of his own issues with Lyme disease, bracketing any arguments about Lyme disease, of just how hard people find it in friendship to respond to chronic illness, where there's no question about, like, I'm trying to help you get over this hump and everything will be fine again. But your new normal requires help indefinitely. What does that mean for our friendship? How do we or will we have this routine of my doing something for you once a week forever? Or what?
Right. And, there's actually a term for that in medicine. We call it compassion fatigue. It's incredibly common, and I see it all the time through the acute crisis. The extended friend network, the community shows up, and then 2 months later, it's maybe them and their spouse, or maybe it's just them.
hmm And again, I think the more you can find more people to spread this over, it's not a guarantee it will work out, but it helps. You can say, okay, well, caring for your spouse is already going to be more than you can sustain alone, but us caring for you is more than what one friend can sustain for you. So, how many people can we bring to bear on this problem so that if many hands don't make light work exactly, many hands make moderate work?
People just need to know what people need when they're in that
hmm
situation. I mean, I've seen many times, let's say people bring cards to the hospital, and while that's a very lovely thought, cards, more paper is the last thing they need. They need someone who's going to bring them food when they're home, or they need someone who's going to help them redesign their house so that there's a ramp instead of stairs, 3 stairs getting up the front door, or help them move, right? Things like that.
Or run the laundry, right? There's a lot of just basic stuff that doesn't feel like it's directly connected to the care, but
Yes,
it's about taking other things off this person's plate.
yes. Going back to ends of life care, just for another beat, you do briefly discuss in the book physician aid in dying, which I thought was really interesting because it is often called death with dignity in many states, which dignity is, the core thesis of your book and in the title of the book. And I do want to name my own position clearly. I support physician aid in dying in rare circumstances. I have personally prescribed it myself, and I've been in somebody's home when they chose to ingest it. And in those cases, it was not because dependence was too much of a burden on people they loved, but it was that situation that we referenced earlier where quality of life was irreversibly gone and it was prescribed and ingested as a form of kindness. So I'm curious, do you believe physician aid in dying is inherently undignified even in those circumstances, or can it coexist with good palliative dependent care?
I will say I think it is wrong, more than I would say it's dignified or undignified. And I think it's the two things that trouble me most are, first of all, the reasons that people opt for it, that when you survey the folks opting for it in certain US states, far more people are citing the fear of burdening their loved ones than are citing the pain of dying. And so I think there's a real extent to which you know, country that legalizes physician-assisted suicide keeps narrowing its sense of what a dignified life looks like or what an appropriate form of love looks like. And the US has been much more fortunate on its slippery slope than other countries, but in places like Canada, you see this just massive expansion till 1 out of every 20 deaths in Canada now is a doctor-assisted suicide. And they keep trying to say, well, should this apply to minors? Should this apply to people with mental illness? And I find that just deeply troubling. But I think the kind of compromise position that we could align on here, even while disagreeing on that biggest question, is I think one thing that makes this really hard is that people have a very limited sense of what a good death that they're aiming for could look like. So, kind of a controlled and medicalized death is the main option we're holding out. But when you think about how people prepare for labor, I don't think the hospital classes are that great, to be honest, but there is some assumption of you're going to go through this hard physical thing that you don't have total say over. So let's at least do a lesson and maybe show you videos of what this looks like. But I think for many people, both the person who's dying and the people around them who love them, this may be the first deathbed they're present at, their own deathbed and their parents' deathbed. And that doesn't leave people well prepared to think,
It often is.
yeah, what am I prioritizing? What could make this better for me? And it kind of leaves you two images, like the intensely medicalized death, which we know many people, especially doctors who see it most often, do not want, and I do not want, of every measure to kind of extend days at any cost, or the probably painless suicide on your own terms. And I just think that's much too narrow a set of options to put before people. But to have something else requires you to see other deaths and have a sense of the range of what your options could be.
This has been shown in the literature too. And in my experience, if you ask people before they're in that position, people really don't have a good sense of what they want at the end of life. And so I think it is futile to try to nail down that level of specificity. And an example of that is even, do you want to die in the hospital or do you want to die at home? Most people say they want to die at home, but then when they're actually in a situation where their caregiving needs exceed what they can receive at home, dying in a hospital is actually not all that bad.
Hmm.
Their preferences change when they undergo a serious illness. And with death, like you mentioned, this is often their only experience. And so the burden is on me, right, or on the medical team to try to best explain and prepare people for what it's going to look like. I will say, though, you mentioned the fear of burden is what people cite for why they want to pursue death with dignity. There are a lot of safeguards in place to make sure that people are deciding rationally and they're not being pressured into this decision because of that fear. And like logistically, right? Like I have to get somebody's signature and then I have to have them come back for an appointment 2 weeks later and make sure they still feel the same way. I have to make sure that there's no family members in the room who might be explicitly or inexplicitly pressuring them to make a decision. And there has to be a second clinician who signs off on it, right? Like I have to send somebody to a palliative care physician. They have the third conversation, identical conversation with them to make sure that somebody is making this choice for what we feel are the right reasons. And I completely agree with you. A wrong reason would be being a fear of burden, their loved ones or the healthcare system.
I think the US has done better than other countries, but I do think a lot of countries take the view that fear of burdening counts as a rational reason, including when they offer uh, assisted suicide for patients who are not terminal, but who have depression and say, this is very hard for me and it's hard on everyone. They go, it is hard on everyone. And wouldn't it be nicer if? And in the UK, where they're still debating their aid in dying law, one of the neurosurgeons who was speaking on it, Dr. Henry Marsh, even said, and this is a direct quote from him, they argue grannies will be made to commit suicide. Even if a few grannies get bullied into it, isn't that a price worth paying for all the people who could die with dignity? And I'm sure that's not everyone's attitude, but it keeps cropping up the sense of that the need is so intense that it's worth some people getting swept in, or even maybe that's what looking at the situation rationally entails, which really troubles me a lot. I would still oppose this if you were the only person making policy, but I trust you a lot more than a number of the other people advocating and leading in this space.
And I think the place, like you said, we definitely align on just the need for seeing that level of dependence as an expected part of the human experience that needs to be taken into account in advance, that needs to be a shared burden. In the United States, it is often the expectation that that burden falls on one family member, right?
Hmm.
Or your spouse and your adult child, but it is not a shared burden among society. And our care institutions are just not set up in a way that recognizes the needs that many people, maybe all people, will inevitably face.
Now, can I ask you a question since you work
Sure.
with cancer patients? Um, what is your own training like, or that of people who work in hospice for how to be ready for their first deathbed, where you are doing it as an amateur, you cannot fully see one, do one, teach one on how to die. But what's been most helpful to you, or what do you wish were in your training for that?
It's the integration of palliative care as a core rotation in oncology training. I think that's huge, and that has made a huge difference in my professional career personally, as well as my colleagues. So it was a requirement that we did 2 weeks of palliative care where it's not a see one, do one, teach one, but we are counseling people on the end of life and seeing people through the end of life on a regular basis. And then you can take that back to your oncology practice.
And what does that rotation look like? Because if I were designing it from knowing less about it. There's kind of a range of we want you to see a wide range of patients, like versus I don't think they come to the break room and tap everyone on the shoulder and go like, this person is about to die, and six of you haven't watched someone die, so we've got to have you come in because that's something where you're prioritizing the families versus also a rotation where you say, all right, like your job is just continuously sitting with this dying person for 2 days. So you have a sense of what the day-to-day moments look like and what it's like to have that sustained presence with someone so you can talk to their family members about what that's like. And those all seem like really different experiences and things to take away from it.
Yes, and you do get those different experiences. So inpatient hospice was my experience where I was the one sitting by the patient who was dying at their bedside and going through the days with the continuity with the same patient and the same family. Whereas outpatient palliative care was more like, we need to discuss the big picture. This person's prognosis is 3 months, or this person's prognosis is
Hmm.
6 months, and we need to have that conversation with them about what their values are so that they could prepare. But I got so much out of the former, right, which was sitting by the dying person's bedside
Yeah,
in the inpatient hospice that then informed me for the range of experiences that then I took back to my own patients when I'm trying to prepare them.
that's great.
I want to ask you, as the final question, what would it look like for medicine to accept and make peace with dependence?
I think a big part of it is always foregrounding that what we are is fragile, and that we are not restoring you to full health, full functionality of what this narrow normal is, versus saying, you are living all the time in an aging body that is headed towards death. And our job is helping you have the fullest life, that's about working with the materials you have as possible. I can understand why people don't open their medical discussions that way, but I think that sense of, you know, your body is something that's beautiful, complex, and very subject to entropy. Gives people a fuller sense of, well, what does it mean then to live a good life in a fragile, perturbable body that's going to have ups and downs and periods of strength and periods of weakness? How am I going to build a life that's hospitable to all those moments versus, well, what I am at my core is a healthy person. And sometimes I get interrupted or sidetracked. And when I do, that's always something going wrong. But what's normal for me is being healthy and strong and perfect.
Leila Bresco Sargent, thank you so much for joining me on Hard Medicine.
Thank you for having me.
Thank you to founding member Matthew Beckman. If this conversation helped you see medicine differently, subscribe to Hard Medicine and share this episode with someone who should be part of the conversation.